So in the previous video, hopefully I convinced you that this 1918 influenza pandemic was a truly terrible global pandemic. It had extraordinarily high levels of mortality, and it swept through the globe in a really rapid manner. So tens of millions of deaths, all occurring within this very short period of time. So obviously a huge, terrible event, but why do economists care about this in particular? Right? So why isn't this just something for epidemiologists and public health researchers? Okay? The reason economists latch on to this is because economists are often on the search for what we call a natural experiment. We don't have the opportunity to test things out in labs in the same way that other disciplines do, in the same way that the natural sciences do. What we would like are experimental setups where some people get treated with something, other people don't get treated, and then we can observe the difference between those two groups. If we had random assignment of people to those two groups, then any differences that emerge, we could attribute to that treatment. But this is rarely what we have in economics. What we usually have in economics are a bunch of people making their own decisions, and those decisions are tied up with their own preferences, their own backgrounds, their own characteristics, right? Their neighborhoods, their parents, all these things are correlated. And so when we see a difference between people that do one thing and people that do another thing, right? People that choose to opt into this federal program, people that don't, we can't say that difference is due to the federal program because the people that opt in have all these different characteristics than the people that don't. And any differences between those two groups might be about those differences in characteristics, not by the effect of that federal program. So what we look for are what we call natural experiments. So we can't put people in the lab and randomize them, right? But every once in a while, the way that history unfolds gives us effectively random treatment. What it can do is every once in a while, it can say this one particular cohort of people is going to get hit with this shock, and the other cohorts right around them aren't, right? And so what that means is that those cohorts, the ones just before the shock, the ones during the shock, the ones just after the shock, give us that kind of experimental setup. They should be facing otherwise pretty much the same conditions. They should have pretty much the same characteristics. What should drive any noticeable differences between them is that shock, right? So that's what we think about when we think about a natural experiment. So the pandemic, at first glance, might not seem like a great setup for a natural experiment, okay? Or at least an experiment that's about a bad health shock, right? Reason being, think about why the pandemic spread so easily. One of the reasons was that World War I is going on. One of the ways that it spread was because of troops moving around to different bases in the US and then moving back and forth to Europe. So if we see some effects from the cohorts that exist right around the time of the pandemic, right? Well, is that because there's this big negative health shock from flu? Was it because of World War I and the health consequences and mortality associated with soldiers in World War I? Was it because of the federal spending associated with running a war, right? We can't disentangle all those things. So from that perspective, terrible natural experiment, and we wouldn't deal with it. But it turns out there's a very unique feature about the 1918 influenza pandemic that makes it pretty useful as a natural experiment. All right, and it's about the way that mortality struck by age group. So here's a graph that shows you what's so special about the 1918 influenza pandemic. Almost all flu years, right? Every year is a flu year. Every year we have deaths from influenza. Every year we have people die from complications from influenza. In almost every one of those years, you get a U-shaped pattern for that mortality, all right? And that's what we're seeing on this graph for 1915, 16, and 17, and then 1919, 20, and 21, kind of typical flu years, all right? If we look at those years on this graph, on the vertical axis, we're looking at mortality, so number of deaths per 100,000 people, okay? And these are deaths from influenza specifically, or pneumonia, all right? And so on the horizontal axis, we're looking at age groups. You get these high levels of death popping up among infants, right? And you get these high levels of death popping up among the elderly. And you get very low levels of death from influenza and pneumonia for teenagers, young adults, average age adults like myself. Okay? And the reason for that is that infants and the elderly have weaker immune systems. And so when you get the flu with a weak immune system, that's when you're at risk for dying, right? But if you're a prime age person, if you're somebody who's a college age student and you've got a nice, healthy, strong immune system, then you're just going to have a bad week when you get the flu, and then you're going to bounce back, right? That's the typical year for flu. 1918, this particular outbreak, the Spanish flu, right, had this really unusual W shape to it, okay? So that's the red curve here, and you still have the high number of deaths among infants, the high number of deaths among the elderly, right? It's still the case that a compromised immune system or a weak immune system is a big problem when flu breaks out. But what's unusual here is that there was also this peak, this rise in mortality among people between 25 and 34 years old, right? So people that are sort of at their prime in terms of work age, at their prime also in terms of when they're having families, right? It's that unusual feature that is what economists are going to tend to focus on. And that's what the first two papers we're going to talk about are going to focus on. Okay? So the key thing here is that the 1918 influenza pandemic was particularly bad for people that are having kids, right? That are at just the right age to be having kids. So this is going to be what lies underneath one of the most well-known papers by an economist on the 1918 influenza pandemic. This work by Doug Almond on whether the 1918 influenza pandemic is over. So he's thinking about the long-term effects of this pandemic. And what he's focused on is in utero influenza exposure. All right? So he's saying, look, this W shape means that people that are having kids are really hard hit by this particular flu. And that means that if there's a kid in utero, a pregnant woman who has a child that hasn't been born yet, right, that kid is potentially getting exposed to this particularly bad shock to the mom, right? So if the mom's really suffering from the flu here, that's likely going to have really bad impacts on the fetus as well. So why is Almond interested in this? Okay, well, he's interested in this because there's been a hypothesis that's been floating around for, at the time he writes the paper, a couple decades, right, or a decade and a half, right? That's called the fetal origins hypothesis. And so what this hypothesis is about is really about trying to explain kind of long-term chronic health conditions, right? Things that are still plaguing you into your 40s and 50s and 60s, all right? Things like issues with cardiovascular problems that are just lingering issues, okay? And so what the hypothesis basically says is that these can be the product of particular health insults to the fetus when in the womb. Okay? So if the mother gets very sick or the mother's malnourished, right, that negative health shock to the fetus can affect fetal development in a way that's going to lead to long-term chronic health problems. Okay? Things that can't be fixed just by, then having a healthy childhood. All right? So why this matters to economists is because this is really important for us to understand how people develop and how investing in people can help them be more productive and lead to higher standards of living, better well-being, right? If we think it's strictly about inputs like schooling, right, and inputs like nutrition while you're in school, then we're not actually going to explain all this variation in the long run with chronic health problems, chronic absenteeism, chronic disability problems, those sorts of things, right? Because some of that might be due to not what's happened when we observe that person in surveys later on, when we ask them questions, right? But actually what was happening to their mother when she was pregnant, okay? That's why we need to know about this. So the difficulty with this fetal origins hypothesis is that empirically it's really hard to test, all right? It's really hard to find compelling evidence that says one way or the other, right? Whether it's in favor of this hypothesis or whether it's against that hypothesis. And there's two key problems that Almond sort of focused on here that he thinks the 1918 influenza pandemic might help with, all right? The first problem is that it's really hard to control for omitted variables like genetic endowments when we're talking about this fetal origins hypothesis. All right? So a lot of studies will look at something like low birth weight as a way to say, okay, well, this kid probably had negative health shocks when they were developing in the womb. All right? But the problem is that that low birth weight could be due to just genetic endowments and not about the mom's health at all, right? And then those genetic endowments are going to continue to cause health problems later on, all right? So in that case, it might have nothing to do with that fetal development, and it's just that the kids that you see with low birth weights versus kids with high birth weights, right? That's all about genetic difference. It's not about fetal development. It's not about the mom's nutrition, the mom's health while carrying the child, all right? So it's really hard to control for that, right? It's because a lot of these genetic endowment type things are completely unobserved. And there's a lot of other omitted variables that are unobserved, okay? The other problem is that this fetal origins hypothesis is all about chronic health issues later in life. And oftentimes we're talking about into your 50s and 60s, okay? Well, any survey that has good data on infant health, good data on things like birth weight and these different scores about like how tall a baby is when they're born, what their skin color looks like, how their breathing is, all these things are used to measure the health of a newborn child, right? We measure them when that kid's born, right? We don't really remember them by the time we're looking at that person when they're 50s and 60s and we look at them in the census, okay? So where we get our data for how people do later on in life is in a totally different place than where we get our data about how people fared when they were infants or how they fared while they were in utero, right? And so if we can't match up those two different types of data, we can't really test the fetal origins hypothesis all that well, okay? So the fact that these effects are delayed creates this big data problem, right? So what have people done in the past to try to think about this fetal origins hypothesis? Well, as I've already mentioned, some things they do is sort of try to get measures of infant health right when kids born, okay? So newborn health. And one thing that we do for that is birth weight. Okay, birth weight is considered this proxy for, how healthy you were during that stage of fetal development. Okay, and so what you're looking at here are some figures from a pretty famous paper by Case, Furtick, and Paxin, where they actually do have information on people all the way from when they were infants up to when they're in their 40s. Okay, so they can actually solve that problem of, how do we look at the long run data? Okay. The problem here is that as much as they find that self-reported health status is related to birth weight, particularly at low birth weights, all right, this is a little confusing because a higher number here is actually worse health, all right? You might think it's the opposite, but it's the way they ordered the questions. So 1 is you're in perfect health, 4 is the worst response, you're in terrible health, okay? So here you can see at very low birth weights, right, you've got this negative relationship, okay? So as birth weight goes up, this self-reported health status, the number goes down, but by going down, that means actually better health, the way this is coded, okay? So at very low birth weights, that evidence suggests that the lower the birth weight, in other words, the worse the conditions for fetal development, the worse the health later on when you're in your 40s or 30s. That's when those questions are being answered. So the other way that people look at things, right, is through looking at things like famines, okay? So if we think about famines, this is a case where we know when the famine happened, right? So there's been some papers written about the siege of Leningrad, which is particularly terrible for the residents of Leningrad. So this is the Nazi siege of Leningrad. It lasts from 1941 to 1944, and essentially during that entire span, this is a dire famine for the residents. And so for kids that were in utero during that famine, we pretty much know that they faced terrible health conditions in utero. We know that their mothers were basically malnourished during the pregnancy. All right, so That seems like a dramatic health shock. And if we know that a kid was born in that 3-year time span, we know they received that shock, and then we can look at census data or something else later on, right, say around 2000, to see how those cohorts turned out. All right. So in the case of case verdict and Paxin, we're looking at individual people where we know their health when they were newborns, okay, and then we can follow them to later on, and we see that relationship between newborn health and health later on in life, okay. In the case of using famines like the siege of Leningrad, right, we're not measuring the actual health of each individual. We just know that they were born during a time period where health must have been pretty bad, and then we observe that birth cohort later on in life. Okay? Both of these suffer from some pretty big problems for testing the fetal origins hypothesis. Okay? In the first case, right, the case verdict Paxin approach here, these people with low birth weights, right, well, they're being born to mothers who might have lots of other characteristics like their income or their own health, right, that are driving that low birth weight. Okay? And maybe it's those other characteristics that actually drive the later health outcomes. So think of a really simple example here. Okay? Really simple example would be, think about smoking. All right? We know smoking is bad for babies. All right? We also know that smoking is correlated with income. All right? So lower income individuals more likely to be smokers than higher income individuals. Okay? So mom's a smoker. That leads to bad health outcomes for the baby. All right? But the bad health outcomes later on might not have been about the bad health outcomes as a baby. That might be about the effects of having a low-income parent through your entire childhood. Right? So in that case, we're kind of misattributing the poor health later on in life to the poor health at birth, right? And we're misattributing it because what's driving that poor health at birth, right, is actually tied to this income channel, which is going to affect health later on through other mechanisms, okay? So it's not actually the fetal origins hypothesis work. So that's the omitted variable problem that I was talking about earlier, right? In this case, income being that omitted variable. So what's wrong with taking this famine approach? There we know that it's this bad health shock, right? That's not the fault of the mom. It's not because the mom's a smoker. It's not because the mom's low income. It's because this entire city was under siege for 3 years, right? So that gets us around this problem of parental characteristics. But this is a city under siege during World War II for 3 years, right? There's going to be a lot of other things that affect this cohort other than just kind of health while in utero, right? This is kind of a massive shock among many, many dimensions to those birth cohorts. And so if we observe bad outcomes later on, we're not going to be able to limit that to the effects of health during fetal development, right? It could be due to any of the other broad range of impacts from a really horrible war and siege and famine. Okay? So that's the big problem we've had with the prior literature. And Allman's going to think that this 1918 influenza pandemic gets around that problem. Okay? So I already motivated this with the W shape of the mortality pattern, right? So this shock is hitting parents particularly hard, right, compared to other influenza years. The other thing about it is that the shock's pretty short, okay? So since the shock hits parents pretty hard, then it's a good candidate for testing the fetal origins hypothesis because that's a negative health shock while kids are in utero, right? How quickly and sort of unanticipatedly this pandemic spread is the other key thing here, right? So it's that fall wave, that second wave, that's the really bad wave of the pandemic. So that's the cohort of kids that were in utero during that fall wave that should face kind of worse health conditions in utero than kids born just a couple months earlier or kids born just a couple months later. Okay, so you can start to see that on this figure here, which is showing mortality rate over the gestation period by month of birth. Okay, so in other words, kids that were born in, say, March of 1919, right? This is looking at the average monthly mortality rate over the 9 months leading up to March of 1919. And the different colors of the bars here are showing the contributions of the first trimester, second trimester, third trimester, right? So remember, the bad wave of the pandemic is right here in the fall of 1918. So kids that are in utero in the fall of 1918 are going to be the ones that are particularly hit in terms of fetal development related to this flu shock, okay? So the kids in utero in those months are being born in the next few months, right? So kids in the last trimester are being born right around that second wave. Kids that were in the second trimester when the shock hit them are going to be born a little bit later, right? And kids in the first trimester when the shock was born, half a year later, up to 9 months later. And you can see that here by those high average monthly mortality rates for this set of cohorts right here. Okay? And it varies as to whether the bad health periods were first trimester, second trimester, or third trimester, right? So those last couple months of 1918, those kids are the ones that had a bad last couple of months, right? A bad couple of months in the third trimester. The last cohorts over here, the ones being born right around June and July of 1919, they're the last ones that were in utero during the pandemic, right? And so their exposure to the pandemic is really bad during the first trimester, right? So the first trimester is accounting for a much bigger chunk of that average monthly mortality, right? But what you can see is that there's this sharp drop off right here because those kids that are born in October of 1918, their entire gestational period was before the second wave hit, right? And then you've got this other big drop off here for August of 1919 births, right? Because those kids were conceived after the pandemic, right? So what we can do then is we've got kids right here that in utero were unaffected by the pandemic. We've got kids over here that in utero were unaffected by the pandemic, right? And then we've got these kids here that were affected by the pandemic in utero. But all those kids have pretty much the same parents, right? These are all kids still being born within the same year of each other, right? So in terms of overall conditions, overall economic conditions, in terms of what types of parents are having kids at this point in time, right? All three groups of kids here are going to look pretty much the same, except only the middle of those three groups actually suffered this health shock while in utero. So if it's not about fetal development, this middle section of kids should have pretty similar outcomes to the groups on either side. If it is fetal development that's really important, right? Well, this middle group of kids should have worse outcomes, noticeably worse outcomes than the ones on either side, right? So that's what Ullman's going to look at, right? So that solves this problem of omitted variables, right? The reason it solves it is because all those parents roughly look the same, right? So what we're comparing is just that difference in timing driven by the pandemic. And that difference in timing doesn't care about who the parents are or what the parents decide to do, okay? So in terms of omitted variables, all three groups of kids here should look pretty similar, right? All right, the other problem though is now we know about this health shock in utero, right? But how do we know about long-run outcomes? Well, this is why it's super useful to have 1918 data, right? Because the shocks in 1918, we've got pretty good estimates of the mortality from 1918, so we can pin down the timing of this shock. But 1918 was a century ago. So we have years of census records well after that. So we can observe people into their 50s, their 60s. At this point, we can observe them up until they're 100, right? So we can see those long-range outcomes. So that's exactly what Ullman's going to do. He's going to look primarily at 1960, 1970, 1980 census data. And so we're thinking about people about 50 to 60 to 70 years old, where some of them got this in utero shock. Some of them, that health shock was out there, but they didn't get it in utero, right? So this 1919 birth cohort, they're the ones that were in utero during the 1918 pandemic, okay? What Diamond finds is they do look very different than the kids born just on either side. Right? So what we're looking at here is years of schooling on average. Okay? So you can see that years of schooling go up over time. Right? This is a period when more and more people are starting to go to high school. So later birth cohorts have higher levels of schooling on average. But the clear deviation from the trend here is that 1919 birth cohort. And they have an appreciably lower average years of schooling than the people born just on either side of them, right? Those people born on either side, they're facing the same educational institutions, the same, big events like Great Depression, World War II. They go through all those things at roughly the same age, right? They face the same job markets, okay? And yet we see this big drop in educational attainment for that one cohort. So that, in Allman's mind, is evidence of the fetal origins hypothesis at work. Okay, so this particular cohort got that in utero exposure to influenza, and now they have worse educational outcomes afterward. It's not just educational outcomes, not just years of schooling. We can look at the percent that graduate from high school. We see the same kind of drop off here for that one cohort. Right? So once again, trending up over time because more and more people are going to high school, but a big deviation from trend for both men and women in terms of whether they graduate from high school. Okay? And then shifting to kind of long-run chronic health issues, we see that pop up as well. So here we're looking at percent with a disability, and it's 1970. So these people are roughly 50 years old at this point. Okay, so not really all that old. And what we see is, first, notice this downward trend. That's just because of age, right? The 1922 birth cohort, they're younger in 1970 than the 1912 birth cohort is. So you age people by 10 more years, you're going to see more disabilities, right? So that's why we have this trend line here. But once again, we get this sharp deviation from that trend. In this case, that 1919 cohort, the ones that were in utero in 1918 during the pandemic, are much more likely to be disabled by 1970. Okay? So that matches up with this fetal origins hypothesis of chronic health conditions, chronic health problems later in life being tied to the health conditions when you were in utero. So we can also go to 1980 and look at that disability rate, right? And we see a similar pattern again. Here we're going by quarter of birth because we can see quarter of birth in the 1980 census. And it's really just for those 2 quarters of birth that were most affected, that spent the most time in utero during the pandemic months, right? That see that high level of disability relative to the overall trend. Okay, so once again, evidence in support of the fetal origins hypothesis. And I want to point out one thing about switching to 1980 here. Notice how much more pronounced this bump is, this deviation from the trend, in 1980 than it was in 1970. Right? This speaks to how important it is to have that long time span for data availability. So let's bring this back to COVID-19 for a second. We're going to have no idea what the long-term impacts of COVID-19 might be on chronic health conditions, right? So we have to turn to history to answer that kind of question. We can't wait around for 50 years to decide whether or not COVID-19 is going to have long-term effects and then design policies based on that, right? We want to design policies now to avert that problem if we think it's going to be a problem. And the way we figure that out is by turning to economic history work, okay? Probably not specifically economic history, but turning to the history of pandemics. So Allman's paper shows us how significant these long-term chronic impacts could be. We can only observe that because we've got many decades of data since that pandemic, right? So this is a case where if we want to have policy lessons for COVID-19, we have to turn to historical data. It's the only way we can actually get empirical evidence of these long-run possibilities.